Welcome to the EKG Guy if this is your first time, and welcome to the EKG of the week. We have here a case of an 82-year-old male whose status posed transcatheter aortic valve replacement, or TAVR, and has this EKG. So what we're doing is we're going to go through this whole EKG step by step to ensure that you're able to interpret it. And what you want to do is go through these things here on the right side: the regularity, rate, the origin, ventricular axis, atrial, AV, and IV conduction, or intraventricular. Go through everything here and look at all of it and try to get a final interpretation. All right, and then you can pause the video now, and when you're ready you can restart it and we'll walk through this together. Okay, so hopefully you had a chance to go through this. This is quite an interesting case that we had recently. An 82-year-old male, status post, or just completed this TAVR procedure not too long ago, and presents with this EKG. All right, so let's go through it. The first thing we want to do is look at the regularity of the rhythm. Is this a regular or irregular rhythm? Okay, so what we tend to do is look at the R to R intervals. That tends to be the easiest. And if you look down here at V5, you can see this R wave in this R wave. Okay, so that's the R to R interval. We want to look at all these intervals between each one. All right, and if you have calipers, you could see that. All right, and all of them here are quite the same, so we would call this a regular rhythm. So constant R to R intervals throughout. The next thing we want to do is find the rate. Okay, and because this is a regular rhythm, there's a few ways we can find it. One of the easiest ways that you can use for both regular and irregular rhythms is that using the standard 12-lead EKG, you should know that from beginning all the way to the end is 10 seconds. And if you multiply 10 seconds times 6, that's 60 seconds or 1 minute. Okay, so what you want to do is count the complexes going across, multiply it by 6, and you can get the rate in beats per minute. Okay, it's a pretty good estimate actually. So what we want to do here is we want to find the ventricular rate. Okay, so let's do that here. We'll use the ventricular complexes, which you can use the QRS complexes or you can use the T waves. We'll use these big QRS complexes and count them. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, and maybe 28 there. So we'll count that one. And what you want to do is 28 times 6. All right, and if you multiply that, so let's do that. 28 times 6, all right, that's 4, 112, so that's about 168 is the rate here. Okay, so as you can see, this is a fast, regular rhythm. All right, now because this is a regular rhythm, there's also another way we can find the rate. So let's just write what we got here was 168 beats per minute. Okay, and because it's a regular rhythm and it's fast here, we can use another way to find the rate, and you want to find one of those R waves that falls on a thick line, which maybe we can use this rhythm or this beat here and see the next one here. Okay, there's that next thick line which comes right before it, the next complex. So it's less than 2. So what you would do is 300 over 2, but it's pretty much less than 2. So it's going to be greater than 150 beats per minute. Okay, and that 2 is because of the 2 thick lines. Okay, those darker shaded lines. So it's over 150 beats per minute. Now the actual machine got 164. Okay, so you can see that first way we do it is a good estimate. All right, so we have a fast tachycardic rhythm, okay, over 100 beats per minute in this adult patient that's regular. Now we have to see where the rhythm is actually originating from in the heart. Okay, in other words, is it coming from the atria, the AV junction, or in the ventricles? Well, in this case, notice that this regular rhythm, but there's no P waves preceding these complexes. Okay, sometimes you can have P waves that are buried in these T waves, all right, and get missed. All right, however, in this case there are no P waves preceding these QRS complexes. All right, so if you imagine your heart here, this is your atrium, right ventricle and left ventricle. We're asking ourselves, is it originating from the sinus node, which is here in the right atrium, the AV node? So this is the sinus node, this is the AV node. You have a Buckman bundle that comes to the left, then you have a His bundle, a right bundle branch, a left bundle branch that has an anterior and posterior fascicle. Okay, So we know that it's not coming from the sinus node or atria because we see no P waves that are preceding it, all right? The other thing is these QRS complexes are not very wide, and that makes it appear that it's likely coming from somewhere in this region, that AV junctional nodal region. Now the QRS width, or the duration, we'll see was 120 milliseconds, so just borderline. And when it's wide, we tend to think, oh, maybe it's coming from the ventricles. There's an interventricular conduction delay that may be causing that slow cell-to-cell depolarization, or you may have some aberrant conduction. In this case, it's just at the upper limit of normal, okay? And you have this regular rhythm. So this is likely coming from the AV nodal area, okay? It's the AV junction, we call that. So that's what we'll say is going on here. It's coming from that area, and it's a fast rhythm. So that should give you the idea that we're dealing with a fast, regular rhythm over 100 beats per minute. And that's what we consider a junctional tachycardia. Let's find the axis here. All right, so the axis, we're going to use the ventricular axis, and so that way we will use the QRS complexes. Remember that normal axis lies between negative 30 degrees and about positive 110 degrees, meaning that all this area here is considered normal axis in adult. This is considered the left axis deviation range, okay, and this would be right axis deviation. And this is what we call no man's land, or a superior rightward axis, or a northwest axis. Why do we call it that? Well, this is north, this is west, so you can imagine this area here is that northwest. All right, not too many things occur there. Ventricular tachycardia can occur there, and is something that is helpful in making that diagnosis. So what we have here is we have to find the axis. We know that lead 1 sits here, okay, the positive end, and lead AVF sits here, all right, at positive 90 degrees. So let's just redraw that here. This would be lead 1 at 0 degrees, and at positive 90 degrees here, we have the positive end of AVF. So let's look at those leads first. They tend to be the most helpful. And if you look here at lead 1, these QRS complexes are mostly positive, meaning it's going towards the positive end of lead 1. And then if we look at AVF, which is this one here, it is actually mostly negative. So it's going to go away from that positive end of AVF. And what that tells us is that the axis sits somewhere within this region. But remember, we said that the axis in this region is normal, okay, but over here it's leftward shift, or left axis deviation. So we have to ask ourselves, where does that sit? And what you want to do is use lead 2. Lead 2 sits here, all right, at positive 60 degrees. And if you know that the perpendicular to lead 2 actually runs like this, somewhat around here. It's essentially that this is positive 30 degrees, okay? That's where that perpendicular line sits to lead 2. And why that's helpful is because if lead 2 is positive, you see positive ventricular complexes, then it's going to be towards this way, going towards the positive end of lead 2 and put you in this region here. If it's negative, it would be going this way, and to say that you would have a left axis deviation in this region here. So let's look at lead 2. So lead 2 is this one here, and notice that these are the QRS complexes, and they are mostly negative. All right, because they're negative, they're going away from lead 2 in this direction, which puts the axis in this region. All right, and actually the axis that the machine got was negative 59 degrees. Okay, so left axis deviation. Negative 59 degrees would be about right here. So hopefully that makes sense. Now let's look at atrial conduction. Well, remember, we said that we couldn't see any clear P waves, all right, and therefore, because there's no P waves, we can't say anything about an AV block, such as like a prolonged PR interval, or anything about that, because there's no P waves that we can see here. And because of that, remember that atrial conduction, or the depolarization, relies on those P waves, so we won't mention anything here. And because AV conduction, we look for any drop beats or any prolongation, but there's no P wave that's preceding it that we can make out. Now what can happen with these junctional rhythms is that, imagine here, they're originating from somewhere in this region. They can conduct down towards the ventricles, but also retrogradely. And because it happens almost simultaneously, you may see retrograde P waves with an abnormal axis as it goes the other way. Now, because this is a regular rhythm, there's no irregularity to the ventricular complexes. We won't say anything about any drop beats or anything here. So AV conduction, we'll say, is pretty normal in this case, okay? So normal here. In intraventricular conduction, this is where we're looking at the width of those complexes. We said that it is slightly prolonged, okay? The QRS duration was 120 milliseconds, so right on the border, okay? Anything at 120 or above that we tend to think is abnormal, okay? So right on the cusp. So there may be something else going on here that be contributing to that, all right? And there are some things. Now the PR segment, just to review the PR segment, so this is your P wave, your QRS complex, and T wave. The PR segments from this point until here. Remember, the PR intervals includes the P wave. Is this. So this is the PR interval, and this is the PR segment. The PR segment, because we're not saying anything about the P waves, there's no P waves, that way we can't say anything about the PR segment. So nothing to say there, all right? Now, are there any Q waves that are appearing? Remember, Q waves are the first negative deflection that precede the R wave of the QRS complex. So this would be an R wave and this would be an S wave. If you had a Q wave, it would occur before it, so somewhere here. All right. So do we have any Q waves that are present? Well, it looks like we may be having some that occur. So look at V4. There's these small R waves that are here, so not really a true Q wave, but V5, you start to see them, okay, more formed. Maybe some R waves occurring here. And then if you look over in lead AVF, lead 2, or lead 3 and lead 2, you can start to see that there is some small R waves, and these are S waves. And again, so not really true Q waves. Maybe here, all right, it's hard to truly tell that there's some there. So there may be some Q waves in the inferior leads, so we can write inferior, and possibly the lateral precordial leads. Now it may represent that there's something acutely going on and the Q waves have not formed yet, all right? And that's one thing to keep in mind. What you can note here is that there is some ST elevation in lead V4. Notice there's elevation in these leads. The ST segment, which is here, is elevated. Same thing in V5. And you may even have some in V3 too, a little bit there, and maybe not so much in V1 or V2. So you do see some in maybe V3 to V5, all right, kind of that anterior portion of that left ventricle. Now the QT interval, we calculate, remember the QT intervals from the beginning of our QRS complex to the end. This is the QT interval. We use the C to mean corrected. It corrects for the heart rate. We have a fast heart rate here. The QTC was actually 502 milliseconds, okay? So prolonged, because remember in males, as we have a male patient here, less than 440 is something that is normal. So this is prolonged in this case. Okay, is there anything else that we're missing? All right, so is there anything else that you can see that we have not talked about? Well, let's look at R wave progression. Remember that R wave progression, these last few things have to do with these precordial leads, okay? So the precordial leads are V1 through V6, so we're strictly looking over on this side of the EKG, all right? And in this case, we do have what's called poor R wave progression. And why is that? Well, notice that these R waves here that we're seeing are not really increasing in amplitude. Normally, you should see from V1 to V5 an increase in the R wave amplitude, okay? Such that if you have something like this in V1, you should have an increase in these R waves as you go. And notice that the S wave, which is this one, here's the S wave. The R wave increases in amplitude, and the S wave decreases in amplitude. Okay, to the point that it's almost absent, and you have somewhat of this ladder here. In this case, you don't see that. The R waves are not progressing up, and that's why we call that poor R wave progression. And that's something that you can see with anterior infarcts, anteroseptal. So big infarcts can cause that. Now remember that these last two things that we're going to discuss depend on lead placement. So if the leads are not placed properly, then they're not always reliant. But it's a good thing to keep in mind. Transitional zone. What this means is where you go from mostly negative complexes, as you can see in V1, mostly negative, V2, mostly negative, V3, mostly negative, V4, mostly negative again, V5, this becomes mostly positive QRS complexes. The normal shift should be between V3 and V4. So because this one is happening after V4 and actually between V4 and V5, we call that a late transition, okay? A late transition, or we call it a clockwise rotation. So hopefully that makes sense. Now we go into, in our our course, we go into much detail about these, but this is what we call a late transition, and may suggest that there's some region of ischemia in that earlier zones, and that's why it's progressing late, okay? So let's kind of take a look at what we've said so far. We have a regular fast rhythm, likely originating from the AV junctional nodal region, and it has a leftward shift. Okay, and atrial conduction, and we have normal AV conduction. We said nothing about atrial because we couldn't identify any P waves, and the QRS duration was slightly on the cusp at 120 milliseconds. Okay, nothing about PR segments, maybe some inferior infarct in the previous. It'd be helpful to look at a previous EKG to identify that. The QTC interval was prolonged, and there may be an acute pattern that we're seeing in that V3 to V4 area with the ST segment changes and the Q wave changes. Okay, so let's look at a previous EKG. What did it show? Well, it actually showed a normal sinus rhythm, okay, and we said this rhythm has changed. It also showed an old inferior infarct. So maybe, in fact, those Q waves that we saw in these inferior leads are there and were present, so it's not an acute injury pattern. The other thing we noted that there was no evidence of any of these poor R wave progression that we've seen in there. Okay, it actually had normal R wave progression. So let's put it together in context what's going on here. This interpretation is actually a junctional tachycardia. Okay. There's an old inferior infarct that may be contributing to the left axis shift, and we don't say left axis deviation if we then code an old inferior infarct, because naturally it would do that. There's also an anterolateral injury pattern, okay? You see that poor R wave progression, so we'll note that here. And then there's these area, V3, V4, and V5. There's this acute, almost anterolateral, so we can say anterolateral injury pattern. Okay. Now this patient, just to give you some context, actually had the procedure, had this TAVR procedure, and then within about 30 minutes after had this severe chest pain, and they had to actually take him back because what happened is the valve, this valve that they put in to replace his aortic valve actually came back and blocked the left main stem artery, okay, and that the left main coronary artery actually feeds both the left anterior descending artery and the left circumflex artery. And as a result, all these patterns here that we see are all new, all right, and this was quite an emergent thing, and they had to replace it. And he ended up doing well, had to go on some CVVH and some dialysis for some time, but eventually had a great renal recovery and is doing well now. So this is quite a fascinating thing. His EKG afterwards actually did improve a bit, and he got better R wave progression here. All right, so something to keep in mind, the rhythm is something you should know. This is a junctional tachycardia. The old inferior infarct is likely pushing it leftward. Okay, he had a previous left axis shift, so that wasn't new, but the new patterns were these ones here. Okay, and something that should really alert you. You know, it should also note that there's some T-wave inversion here that's also present here in V6, okay, on those lateral components. So anyways, that's it's quite interesting, and just let's not forget the prolonged QTC that we noted here. That's something that you can see with ischemia or any infarct pattern. So quite fascinating case. He's doing well, which is always the best thing. But the final interpretation, junctional tachycardia, an old inferior infarct that was there previously, poor R-wave progression, prolonged QTC interval, and this acute injury pattern, the anterolateral portion of the heart, and likely fed by this left main coronary artery by the LAD and the left circumflex. Okay, well, that's the end of this lecture. I hope you learned something. Now, just to keep you in mind of our course material that we have available, so again, if you go to our website, www.ekg.md, okay, so this is our website, and what you'll notice is that if you go to the EKG course here, okay, you'll find stuff that's separate. So notice that we have a number of topics, practice material, lectures, a way for you to contribute, and this is the course here over here. So you'll notice we have over 300 videos or so, and that's more on YouTube. There's another 100, more than 100, about 200 videos that are available with the course. So those are separate videos, and this course is really designed to take you from a beginner to advanced interpreter. Okay, so completely separate from what you're getting online for free. Okay, these are course material that comes with it. So notice that you have a book. Okay, and then you also have the pocket guide available, so you can choose which format. They are the same thing, both these book and the pocket guide, different formats. I really like this small one because you can keep it in your white coat if you're in the clinic, or in your pocket, and it's really available on the go. Now, with the book, you also get videos. So notice these are the videos, okay? And these are a video for every single page in that book. So it's over 30 hours of video. Now there's a number of practice material that I continue to upload there. Okay, we'll have practice questions coming soon. So all of that's available. Again, this is separate from all the free material that you get already. Okay, so this is more high yield stuff. This is what we used to teach our technicians here and our students here at Mayo Clinic. And it's used now among many institutions. So check that out. Now, what it also includes are calipers. So yes, you get calipers with this course. Okay. I don't know anyone else that offers that, but you do get calipers. I think they're very helpful, and they can, if you know how to use them correctly, can help to identify different arrhythmias that are going on. Okay. And then you also get our pocket EKG reference. Okay, this was something we've put together as we were developing course for the fellows, and this is really nice. It has every code, as you saw earlier, laid out there. Very small pocket guide available. I had help with my colleague, Dr. Peter Noseworthy, who's the head of the EKG lab here at Mayo Clinic, in editing it. So this is something that we use, and we found very helpful. So go to the EKG course. You'll see examples of lectures, okay, why we developed this, okay. A lot of it came about from myself struggling with learning EKGs, having a father that was an interventional cardiologist, and, still struggling. So my struggle is a struggle that I don't want you to have in learning them, okay. You can read all those introductory books, but honestly, they are not enough, okay, and you find yourself using other resources, which is part of the learning process. I wanted to expedite that process for you and make it less inefficient in pretty much what I struggled with going and learning through EKG. So again, from beginner to advanced level with this course, you get the book, the calipers, the coding reference, video access, okay, and now we're offering 25% off. 25% off. Put that code in on checkout, and you'll have yourself 25% off that will even, it's pretty much covers the cost of what we use to print the material. So we don't really make much off it. It's more to help our learners grow and really be able to contribute to patient care. That's why we do this, and we love doing it. So thank you so much for your support. If you have any questions, just leave them below, and we're happy to answer them. All right, have a great day.